so much for tuning in to the Birth It Forward podcast. Don't forget to like, subscribe, and let's get ready to hear from some doulas who know squat. Hello, I'm Kristen Mason with Birth It Forward, and I am so thrilled to be joined today by the Division Women's Specialty Educator for HCA Healthcare, Jackie Asherman. We are going to be talking about the new Eat, Sleep, Console protocol to help support mothers and babies through neonatal abstinence syndrome. This talk is focused on educating people who will be supporting these mothers, such as doulas and family members. Enjoy.
Hello, I'm Jackie Asherman. I wanted to talk to you briefly about the Eat, Sleep, Console protocol that we use when a baby is withdrawing from neonatal abstinence syndrome is what we call neonatal withdrawal, or the withdrawal of a brand new person. And typically this is caused by maternal substance use. So let's talk about that a little bit. And here's the objective. So at the end of this session, I'd like you to be able to understand what neonatal abstinence syndrome or neonatal opioid withdrawal syndrome is, be able to talk about the way that we assess and take care of these babies and the couplet, so the mom typically and the baby, and then understand why we use the Eat, Sleep, Console method, and then feel more comfortable supporting the mom and the baby when this is a factor. Abbreviations that we'll use in this little presentation are NAS, and that stands for neonatal abstinence syndrome. NOWS, or NOWS, is specific to neonatal opioid withdrawal. Typically, things that we see are babies that are withdrawing from morphine, oxycodone, methadone, or fentanyl. And then ESC is just short for the Eat, Sleep, Console method. For simplification, mother/caregiver is used throughout this presentation, but the baby's primary caregiver might be the father or a grandparent or a foster parent or other significant person. So just know that. So we think that about 6 to 20 babies per 1,000 in the United States currently is impacted by withdrawal syndrome. And this can lead to long-term healthcare impacts on those babies. And the appropriate assessment and care of these babies just promotes better bonding for the family, and also just better long-term outcomes for the babies, both psychologically and physically. So really important that we get them off on the right foot. So a really brief history of neonatal withdrawal syndrome. The very first paper that was ever published on this was published in about 1875, and they called it congenital morphinism. So this was exposure in utero to morphine that at the time, the thinking was, hey, this is not a harmful substance. This makes the mothers feel better. And they didn't understand about addiction at that time. And in this first study, 9 out of 12 of the babies actually died either in utero or shortly after birth due to withdrawal from the medication. And the neonatal mortality rate, so babies dying, this remained really high through the 1950s. And then at that time, methadone therapy became available. And methadone is a controlled way that people who are addicted to opioids can withdraw from the opioids safely. It's really dangerous for a mother, someone who's pregnant, to quit an opioid cold turkey if she is addicted to it, because the outcomes for the fetus could be death. So really dangerous. So that's why when we see a mom who's using methadone to come off an opioid, this is actually a really positive thing. It lets us know that that person is getting help for their addiction, and that we're more likely to have a better outcome for the baby. In the mid-1970s, there was a heroin epidemic in the United States, and it kind of focused on the Philadelphia area. And there's a pioneer physician named Loretta Finnegan, who believes she's a pediatrician and a psychiatrist, but she developed a tool that has been used ever since called the neonatal abstinence scoring tool. We know it as the Finnegan scale. And it was really groundbreaking. There was nothing used like it before. And the Finnegan scale was used to take a look at, like, hey, how are these babies doing? And do we need to intervene by giving the baby a little bit of morphine to help them wean off of the opioid? But there were some challenges with the Finnegan scale, and we'll talk about that in a minute and why we're shifting away from that. So it wasn't until 2014-15 when a pediatrician named Dr. Grossman at Yale developed what's called the Eat, Sleep, Console scale. And the difference between the Finnegan scale and the Eat, Sleep, Console scale is that with Finnegan, morphine is the medicine or the treatment. And with Eat, Sleep, Console, the mom or the caregiver is the medicine. So complete different shift away. And we feel like it's in a really positive, healthy direction. So the problems with the Finnegan scale, first of all, it's super lengthy and needs completed on a very frequent basis in the nursery by a healthcare provider. There's a whole bunch of different criteria that need to be looked at. And if one nurse or physician scores a baby, their score may be very different than that of another nurse or physician. So there's a lot of what we call inter-rater variability when this scale is used. And the reason for that is a lot of it is subjective. Like one of the criteria that we're looking at with Finnegan is like excessive sucking for a baby. Well, who defines that, right? Is who gets to decide that? And then the other thing, there are things like frequent yawning and sneezing. Did they sneeze more than X number of times in 30 minutes or yawn more than X number of times? And as healthcare providers, we just don't have the time to sit there and loom over a little person and really be able to determine that. But the score is so important that it be accurate, because if they got a certain score, then we would initiate morphine treatment for withdrawal. The other issue with Finnegan is it requires a baby to be stimulated in order to properly use that scale to assess them. For example, we were looking for, does the baby have an exaggerated Moro reflex? And the Moro reflex, that's the one where the baby will startle and put their arms out like that if there's a loud noise in the room, and that's a normal newborn reflex. But we're looking to see with these babies, according to Finnegan, do they have an exaggerated Moro reflex? And in order to do that, we got to unwrap them and make a startling noise to see if they have an exaggerated response. And, as healthcare providers, we first do no harm. There's the ethical principle of non-maleficence, which just means like we don't do harm to our patients. And potentially by unwrapping them and startling these babies whose nervous systems are a little off kilter because of the exposure to the opioid, we're potentially doing harm to them. So we got to get away from doing that. With Finnegan, an average of 62% of those babies required morphine to get through that withdrawal period. And they had an average length of stay in the hospital of 16 days. So that's a really lengthy amount of time for that baby to be away from the home setting. So why should we avoid the use of opioids? So opioids to help a baby withdraw, if they're necessary, are a great thing. But the American Academy of Pediatrics in 2012, so like this is 23, this is 11 years ago, they said, hey, withdrawal from opioids is a self-limited process, and we shouldn't use these opioids or morphine with a baby unless we have to. And so how do we know if we have to? And we want it to be as objective as possible. So let's take a look at the Eat, Sleep, Console model. See the gold star there. And this is really exciting because gosh, if you just look down at the bottom, the average length of stay when we use this very simple method to assess and care for the babies drops all the way down to like over 10 days shorter length of stay. And only 12% of them end up needing morphine when we use Eat, Sleep, Console. So what are we looking at with this method? Yeah, huge difference, right?
So much better. Oh my goodness.
Yeah.
All kinds of things that would affect in a positive way from that change.
Yes, absolutely. That mom, getting home with her baby sooner,
Mhm.
um, you know, cost, I know that's not the biggest factor, but, just
But it's
cost
a
a
factor. Mhm.
yeah, absolutely. Initiating and supporting a good breastfeeding relationship. Much harder to do when that baby's an inpatient, right? Than when mom is settled into her own space in her own home. Um, yeah, so huge difference with length of stay. And Eat, Sleep, Console is just a lot simpler because it looks at like, can the baby do their job description? So
Mhm.
if we simplify things like what's in a baby's job description, and this is what Dr. Grossman at Yale, he gives a great talk on this, but he says, hey, a baby needs to eat, they need to be able to sleep, and they need to be consolable. So if they can do those three things, cool, thumbs up, keep going.
Pretty much it.
Um, yeah. And then that shift away from like, hey, the only thing we can do with these babies is morphine, to guess what? The mom or caregiver is the first line of treatment for these babies. So big shift in a really good positive direction, I think.
Mhm.
So what babies are eligible for Eat, Sleep, Console? Well, they have to be pretty close to term, so they have to be at or greater than 35 weeks gestation. Typically, the most common substances that we're seeing are heroin, fentanyl, prescription pain medications for like a chronic pain issue that the mom has can also cause neonatal opioid withdrawal. Methadone is another really common one.
Mhm.
Um, and in the hospital, we're really upfront with the families. Any baby where we know that there's an exposure to an opioid, um, those babies will all have a urine and meconium toxicology drug screen performed so that we can see exactly what's in their system. And that helps us if they start having withdrawal symptoms that can't be controlled just with comforting. That helps us know what medication we need to give them to help wean them off of the substance. So, um, mothers who will also have drug screens and have their babies drug screened are those that don't have any history of prenatal care. That can be a red flag for substance use. It does not, typically it's not anything to do with substance use, but that's when we would routinely screen a baby. And again, we are always honest with our parents and our patients about that. So we don't try to be sneaky about anything, but it's just about being able to provide the best medical care for that family. Um, so average length of stay depends on the substance that's used, but it's anywhere between 3 to 5 days when Eat, Sleep, Console is used. Um, and we're working really hard to educate the nursing staff so that they can be very supportive and provide families with education on how to comfort the baby and how to support the baby. But this is where someone like a doula can really make such a huge difference, because the nursing staff may have, two other couplets that they're caring for, and the doula, if available, could be there present with the family and teaching those comfort measures that we'll show you in just a few minutes. Most babies, if they're going to show signs of withdrawal, will do so within 72 hours. So this little chart kind of shows an average of how long it takes for babies to show those signs. So again, we're looking at methadone as being something that we see a lot of, but initially that baby may come out and, just act like a baby. And then 48 hours later is when they might be showing those signs of withdrawal. So that's why we really want to keep them 3 to 5 days to make sure that we're not missing that.
Okay. And then
So,
here where it's talking for cocaine and marijuana, I get a lot of marijuana questions with my clients.
yeah.
Um, what exactly are they looking for dysregulation? And is there anything that needs to be done about that if they're born being kind of dysregulated, or is it just something that you notice?
Yeah, so with those babies, they can really benefit from occupational therapy. So as part of our normal hospital protocol with Eat, Sleep, Console, we're consulting occupational therapy so that we can have them available to support the family with different activities they can do with the baby, ways that they can promote nervous system stability in these babies. So dysregulation may look like, a baby that just can't get on I don't want to say routine sleep schedule because what baby has that, but these are babies that are really all over the place with their sleep. They might even might be sleeping for super long stretches or only sleeping for 5 to 10 minutes at a time, waking up startled kind of thing. So that kind of dysregulation, as we can imagine, would be really challenging as the caregiver, as the mom, but also for that little person, they're just burning lots and lots of calories when they're dysregulated. So did that answer your question?
Yes, thank you.
Okay, yeah, you're welcome. So what exactly does eat look like? What's a yes on eat? They're eating adequately. And it really depends on a few things. Are they bottle or breastfed? And how old are they? So this kind of gives us an idea of what we expect on day one, for example. So this is just one view is we're just looking at the baby's ability on day one to coordinate a feeding at the breast within 10 minutes. So this is our breastfed baby. They may not be able to suck and breathe and swallow for 10 minutes straight, but we want them at some point to be able to show us that they can do that at least a few times on day one. And then on day two, we'd like them to suck, swallow, and breathe and sustain that for at least 10 minutes. But there can be other factors involved too, like does mom have inverted nipples or does the baby have a tongue tie, something like that. So we're not just looking at this alone. We're always looking at the big picture and trying to provide support. So we would have lactation support, assessing that baby and taking a look at mom's anatomy and making sure that we're providing support that's appropriate. So if the answer to can the baby tolerate feedings is no, and we think it's due to opioid withdrawal, for example, then that's when we would huddle with the care team at the bedside and see really what do we need to provide resource-wise to this family, to this mom and baby, so that they can be successful. And then the second one is sleep. So can the baby sleep greater than an hour after a feed? Is that a yes or no? And again, we're looking at the big picture, like, is the room quiet? Are the lights down? Is the TV volume off or low? So we have to provide an environment where the baby whose nervous system is more irritable, where they can actually sleep. So we're not putting them in, with a jackhammer going and saying, hey, why can't you sleep? Yeah. And then console, is the baby able to be consoled in less than 10 minutes? Yes or no? And if the answer to any of these is no, and it's due to opioid withdrawal, then that's when we would huddle with the care provider. So typically pediatrician or neonatologist, the nursing team, and the family, of course. And if there's a doula present or a baby cuddler present, they would be looped in as well so that we can try to figure out, is there anything different that we need to do to support this baby through this situation? One thing that's really important is using a bland barrier cream or a diaper cream with every single diaper change, starting from the get-go. So the very beginning, we want to put that diaper cream on, because babies who are withdrawing from any substance tend to have diarrhea. And it's very acidic, very watery diarrhea, and it can literally, burn their skin. And that can be obviously very painful for them. So we want to protect that bottom area, that diaper area, with the barrier cream every single diaper change. Because if their bottom hurts, they're not going to be consolable or sleep well or probably eat well either. So that simple thing can make such a huge difference. Any questions about that? I'm just yakking away here. I'm so passionate about this topic.
I love that you're yakking away. It's fabulous information. It's very thorough, which is making me not have a ton of questions. I am I would like to know a little bit more about, you said cuddlers. Is that something that is volunteer, something that your hospital, something that people could sign up for to help if they're wanting to help with this and they're not necessarily a doula, or they are a doula and cuddling babies just sounds great to them?
Yeah, that's what I want to be when I grow up, is just a baby cuddler. But
Yes.
yeah, so most hospitals with a labor and delivery unit will have some type of baby cuddler program. At Overland Park Regional, and in Overland Park, they have what they call warm arms. And those people volunteer for that. What a great thing to volunteer for. But they go through the volunteer services department at Overland Park and are, vetted and so forth and receive training. And those people just are, man, such a high value what they bring to those babies and to those moms, because you can imagine like maybe a single mom or somebody that doesn't have a lot of family support, or dad's got to be home with other kiddos, for example, and we have a baby that's withdrawing from something and they're very fussy. Mom is probably she'll give it her all to comfort and cuddle that baby. But at some point she's going to get tired too, because she just gave birth, right? So to have somebody who's available to come in and rock that baby right there in the room with the mom while mom rests is just invaluable. So yes, highly encourage anyone who's interested to volunteer for that. Such a high need for that. Yeah. So this talks a little bit more about what the huddle is. So if we have a baby who's not eating or sleeping or consolable, then we huddle with the care team, the family at the bedside, and hey, everybody's just putting their brains together and being like, hey, what is there anything we can think of to do? Can we move them to a quieter space on the unit? Do we need to get a baby cuddler? What does this baby need? So that's where everybody comes together. And if there have been a couple of huddles and baby is still fussy, unable to sleep, unable to eat, they're burning a ton of calories. That's not what's best for baby. So at that point, the provider may say, hey, you know what, let's move this baby to the NICU where they can have 1 or 2 doses of morphine to sort of help get them over the hump with this.
Yeah, I feel like that's another opportunity for doulas to be supportive, is knowing NICU protocol, and being able to sit down and talk to their clients and support them through that. Having your baby taken to the NICU is an experience of its own, especially if you don't know that that's a potential prenatally and haven't been able to get that education beforehand.
Yeah, absolutely. And I think the physical needs of the mom may make it really difficult for them to, go up and stay in the NICU with the baby. Whether mom's, given birth vaginally or through C-section, it's really hard because there's not a bed for mom typically up in a NICU. And yet we want that consoling, that comfort, that hands-on comfort to continue for those babies up in the NICU. So this is where someone like a trusted family member, a doula, a baby cuddler can go up with that baby to the NICU and, be mom's arms and comfort the baby when mom can't necessarily, or give mom breaks so she can go back and rest. But
in the case of a baby going to the NICU specifically for morphine, does the graduation rules kind of mirror or are exactly the same for babies brought into the NICU for birth weight or other care needs?
by graduation, do you mean discharge?
Yes. Yeah.
Yeah. So typically babies need 1 to 2 doses of morphine to sort of get them over the hump. Every once in a while, there will be a baby that does need to be on scheduled morphine, and that would be a longer inpatient stay if that was the case. Regardless of the length of stay, we want that family involved, at the bedside with the baby, cuddling the baby whenever possible. But we keep the babies, I think the protocol for us is about 48 hours after their last dose of morphine. And we just want to make sure that their symptoms don't return, and also that they keep their oxygen levels up and so forth. And then the reason babies need to go to the NICU typically when morphine is used is so that we can place them on a monitor. Morphine is a respiratory depressant. When used, carefully and in teeny tiny doses, doesn't obviously usually have that side effect, and we're very careful, but we monitor the babies that are on morphine. So that's why they have to go typically from a postpartum unit to a NICU. Yeah.
Do the
So
same eating requirements and sugar levels and those benchmarks for graduation apply? Because I know that they're higher in the NICU than they are like to be discharged from the NICU. The benchmarks are higher than to be admitted into the NICU. These are just questions that my clients are going to have.
Yeah, sure. So it really depends on the big picture of what's happening with that baby. If that baby has had blood sugar issues, then yeah, that could be a criteria that they maintain their blood sugars for a certain period of time. So it kind of depends on the big picture of what else might be going on with that baby. So, if they do end up needing morphine, it is typically a longer length of stay than 5 days. But still much shorter on the Eat, Sleep, Console protocol than the 16 days they might get if the old scale is used. So it's moving in the right direction, but yeah.
Well, and if they need to stay there because they need the help, then they need to stay there because they need the help. And we're grateful that it's available.
Yeah, for sure. And Kristen, I'm sure that you know this, but when a doula or warm arms volunteer go to the NICU, like I'm wearing rings and a watch today, I would be bare from the elbows down. So just know that you would need sleeves that you could push up. You would need to do a 3-minute scrub when you walk into the NICU, just to keep infection risk down. So they would ask you to do that. So just heads up that you'll probably be asked to do that if you end up following baby. So non-pharmacologic interventions, Kristen is going to demonstrate some of these for us, but we'll start first with, just the rooming in. We want that mom and that baby to stay together. Babies do better. We really encourage skin to skin. Rooming in, that promotes breastfeeding and bonding and all those good, yummy things that families need. Support shared decision making with the mother/caregiver, and just irreplaceable, keeping that mom and that baby together. If we look at vital signs of both mom and baby, both sides do better when they're together. There are situations where it's not safe to do that, but it's pretty few and far between. But anyway, so let's move on to some skin to skin, which I'm sure you guys are all familiar with what skin to skin is, and it's exactly what it sounds like. Typically baby's laid right on the chest, bare skin to bare skin, nice warm blanket over the top, and that really helps baby regulate their heart rate and their breathing. Babies that are agitated or have higher metabolic needs, so they're burning more calories, and that's not what we want for these little critters who need to pack on the weight. So skin to skin also increases milk supply, so that's good. It's important though to remember that when mom places baby skin to skin, or when baby is at the breast, mom's going to release hormones that are fabulous because they help her relax, but they might make her sleepy. So really important that if she's skin to skin, that somebody else is in the room, just to be watching, because we don't want mom to accidentally drop the baby, fall asleep in the bed with the baby, and have there be an unsafe situation where nobody is awake and watching. So that's another way that a doula or cuddler could help. And then swaddling, Kristen, I don't know if you got a blanket there, maybe you don't, but swaddling, we swaddle in a really specific way. So we like to keep them feeling tucked in their upper body, but we want their legs to be able to move. That's important for proper hip development. Obviously, we're going to watch the baby's breathing, make sure that we don't have that upper body snugged too tightly. We want their arms flexed, and I'll show you a picture of what that looks like. Flexed with their hands close to their mouth. And I think, here we go. Here's a nice picture of that. So we want the baby to be able to self-soothe by bringing their fist to their mouth. One thing I want to point out in this picture, we have this nice, beautiful knitted hat and this tight blanket, but be really mindful that babies that are going through withdrawals get really hot and sweaty. And so that can cause skin breakdown, especially in the skin folds. So just be really careful. We're watching that baby's skin and making sure they're not getting too hot. Cuddling, this is a great way to make baby feel safe. I'm gonna let Kristen demonstrate.
Okay, so for when I'm swaddling baby, I always start by folding up here at the top. Trying to think, I would need a second hand to kind of be able to lay the baby flat, which is what you do. So you take baby and you're going to put the blanket across like under their head. And then this arm is going to go down and you're basically going to take the blanket. Well, you're doing up. So have the arms up for the hospital and wrap around. The baby able to cuddle that hand. Do you do both arms up?
Yes, or one arm free. And yeah, it depends on how the baby does, but.
Okay, so for this one, let's say we'll do up here. So you're gonna have a tail that you tuck up and then you wrap the other side and it just goes around. And then, yep, they look like a little burrito. And so you've got the baby able to suck on their hand just like that. In a more traditional, you would purposely put this hand down, but I like this. I'm going to try this with an overnight that I'm doing tonight and see if baby likes being able to suck their own little hand.
Yeah. Yeah, that's self-soothing. So one of the things that we're looking at with can the baby console, the optimal thing is that the baby can console themselves. You know, we're obviously there in the room with the baby and there to comfort, but if a baby can self-soothe by sucking, that can be really good too. So thank you so much. What a beautiful swaddle. Can tell you've had a little, right? I bet you have. Yes. So now Kristen will demonstrate, we call this the crescent moon hold. And this is where the baby's chin is tucked right down to their chest and their arms are forward and their back is rounded. We want the legs to be slightly bent in an upward position. And that little baby doll, I don't think bends their knees, but we want the knees will kind of be.
There we go.
Oh, there we go. Perfect. Yeah. So this is the crescent moon hold. And see on the bottom picture, that's we don't want the baby to have their back arched backwards. We want it in a nice rounded, cozy C shape. And also we want the knees bent. And that's really comforting for their nervous system. And then the next one is the C position, facing out. And, you know, for those of us that are experienced with babies or we've had babies, this is something we might do naturally, but someone who's never had a baby, especially, and then you add on top of it a withdrawal situation, they may really need to be shown how to do this. But this is also super comforting for them. They love to feel that warmth and the nice stable torso of the person that's holding them. And then the elevator rock. This is
gassy.
Oh, that's a great one. Yeah, absolutely. That could be so soothing for a baby with gas too. that downward gentle stroke on the tummy. Yeah. And then if you have a baby that's, boy, they're really worked up and their faces beat red and they are just screaming, they're frantic, maybe they've gotten to a point where they're super, super hungry. We'll show you some pictures of what that looks like in a minute, but you can do what's called the elevator rock. And this is where you hold the baby as little as a couple inches away from your body. And then you rhythmically rock up and down slowly, just, 3 or 4 times. And those vertical movements can really help reset and calm their nervous system. It's really amazing how this can work sometimes. So a great one to demonstrate for a family.
Like this,
and then
do a little booty shake at the end.
Oh, perfect. Yeah.
Part.
Yeah.
Great.
That's great. That's great. Yeah. And then the clap and sway. So again, those of us that have kiddos and we taking care of lots of babies, we do this naturally, but somebody who's never had a baby before, doesn't have experience, may not do this naturally. So demonstrating this for them. And this is so comforting for them. And, tell the mom, like, you don't want to hit them hard, right? But we're patting hard enough that we're actually moving the baby's body a little bit with our pats. So sometimes I think especially a first-time parent could be a little too gentle and the baby's just irritated by it and not comforted by it. So I think, yes, exactly, right? And then some additional things that we can promote mom doing is breastfeeding on demand. We recommend this anyway, but particularly for these babies. Okay, they just ate an hour ago. Well, guess what? They're hungry again. And they're burning more calories when they're withdrawing. So it's understandable that they're going to need to eat more frequently. We don't typically recommend pacifiers for a breastfed baby, but in this situation, sucking after they have a full tummy can be very comforting for them. So this is one situation where we would offer those after feeds. We talked already about using the diaper cream, and then something called cluster care, where we're clustering together all the things that baby needs. So if baby needs to eat, we would feed them and then change their diaper. And then, maybe the nurse could come in at that time and assess the baby. So we're trying to cluster all those things together. Don't feed the baby and then wait a little bit and change the baby and wait a little bit and have the nurse, unwrap and assess the baby. We're trying to cluster it. So everything's done. And then baby has these pauses where they can reset and rest. Super important. Things like quiet environment, dim lights, limit visitors to people who are there just to support the mom and the baby. This isn't a time for the excited, high-pitched relatives to come in and be like, hey, so glad to meet you, and oh my God, and here's the balloons. And there's time for that later. This is a time to be like...
It's always such a hard conversation to have, too.
Yes,
It's
right.
one of the things that you help with prenatally, setting the expectations for the really excited.
Yes. And God bless them. They kind of can't help themselves. Yeah, they're happy. They're happy, yes. But it's like, read the room, yeah. So really just promoting that calm, quiet environment. And the nurses are always willing to be the quotes bad guy. So, mom might have a code word or something where she says like green jello, and that means like everybody goes out. Do you use that too?
Yeah.
Okay. Yeah.
We have code words for everything.
Yes, right. It's really helpful. And, yeah. And then super important, early recognition and response to hunger cues. So let's take a look at that. So the top 3 babies there, you can see like that's the early cues. And that's when we want mom to place baby to breast or feed the baby the bottle. So baby's just stirring, mouth is opening, might be bringing the fist to the mouth, turning the head and maybe rooting a little bit. And then the kind of mid cues are baby saying, hey, like getting really hungry here. They might stretch and move around more, really be chomping on that fist. the late cues, we don't want the babies to get to that point where they have to say, scream and be like, hey, like, feed me now kind of thing. If you do end up like kind of missing the early cues and the mid cues and baby ends up frantic, you got a trick for it, right? Do that elevator rock that Kristen demonstrated, or the rock and pat could be really good too. And then medicine treatment, we talked about that. So this is where everybody's tried everything that we can, and baby is still not eating well, sleeping well, and is not consolable. That's when medication may be the best option for the baby to get them over the bump and get them on their way to recovery. So most of the time, 80% of the time, 1 to 2 doses of morphine is all a baby will need. And most of the time, these are needed on days 3 and 4. So if you're a doula or you're a baby cuddler and you know that you have a patient in the hospital in this situation, anticipate that on days 3 and 4, those are going to be the toughest days potentially for the family and for the baby. That might be when morphine is needed, or it might be when extra support can get the baby over the hump without needing that. So just be really mindful of that. But like I mentioned, even if baby ends up going to the NICU, we still want to do all the good, yummy, comforting things. The baby may need held most of the time. If that's what they need, that's what we want them to have. And it can be really challenging for nursing staff to provide that, given, patient volumes and so forth. Really depends on what's going on. But we want those babies to have that if they need it. So, and that's where a doula, family member, baby cuddler can just make such a difference for these families. We talked a little bit about discharge criteria and how, typically we want them to be in hospital for at least 48 hours after their last dose of morphine. But if, they're low risk for withdrawal symptoms and they've gotten through those 72 hours and they are not having any symptoms, they can probably go home. If they're higher risk, where mom's been on something like methadone for a while, they may need to stay that full 5 days until we can, safely and calmly say, yeah, we think that you're good to go home with baby. Yeah, we're also looking at other things like weight gain, like we would with any baby, and trying to intervene before there's been too much weight loss. I mentioned that babies in withdrawal, they burn lots of calories. So if they're a formula-fed baby, they may need their formula fortified with a few extra calories to kind of prevent them from losing too much weight. And then all babies going home, we want them to have a in-person follow-up with their pediatrician within 48 hours. You don't care about nursing documentation. So here's a little case study. Let's just pretend that you're coming in to support a family that has a history of drug addiction. And baby's 2 days old, full-term infant, prenatal methadone exposure, which is a high-risk medication. We're going to want to keep this mom the full 5 days and the baby 5 days. Mom's rooming in with the baby, the lights are down, the TV's off, everybody's using quiet voices. Mom's giving frequent skin-to-skin contact, baby's exclusively breastfed. Mom doesn't have a partner present or any other family support present. There's a cousin who's flying in from another state but can't get here for a couple of days. The baby is sleeping for 1 hour after feedings, and while awake, the baby consoles with rocking and patting within 3 minutes. So everything's looking good. But what do you think this mom's main need might be at this time?
Well, she's gonna need to be able to care for herself, someone to hold the baby so she can sleep. There are no co-sleeping allowed in hospitals. Especially, we wouldn't really want a co-sleep with methadone in the system anyway. So that's going to be a big one, just honestly holding the baby so she can take care of her own needs. And then this is 2-day old. So day 4 is the one you said that we might just not be showing symptoms yet.
Yeah, so days 3 and 4, yeah.
Mm-hmm. So making sure that she does know kind of what to look for, looking for those things yourself. And if education, like if she has questions about, the chart, because I know you said, well, when we talked earlier, you had said that you try to get the chart to them prenatally. And at the very least, she'll have access to that chart during that time. And so a lot of times as a doula is just showing the options of these are the things that may come up, and having that conversation with her while she's having something to eat and you're rocking the baby, for example, would be something I would expect to do in this situation.
Yeah, boy, you hit on all the high points. That's wonderful.
Thank you.
Yeah, so most of the time the methadone is, actually, I don't know any hospital that administers methadone. So it may require the mother to physically go to the methadone clinic. So in this particular situation, mom's going to need somebody to stay with baby, and it's better that baby stay in the room with a designated caregiver than, being shipped off to the nursery where they'll take beautiful care of the baby, but they will have multiple babies. So, um, finding out where's the methadone clinic, what time do you need to go? And typically the methadone is once a day dosing. So a mom might need to leave the hospital early in the morning, be gone for a couple hours, and then come back. And so, filling that gap, providing that comforting and feeding for baby and so forth.
So would she be going without the methadone until she's discharged at 24, 48 hours?
Yeah, great question. So typically the methadone dosing is once a day, is my understanding. So mom probably the day after delivery is going to need to go and have a dose of methadone. Yeah, and you can see how challenging that in and of itself would be for a mom, especially after like a C-section or something.
Yeah, that was my thought.
Yeah, for sure. And then just depending logistics, like, does mom have somebody to drive her? There's all kinds of needs that a doula potentially may be able to assist a mother with or family with if there's not a family member. So, yeah. So what do you think?
Awesome. This is great information. I'm so happy that this is being implemented. It seems so much simpler and effective, which is what we're looking for in this. Thank you so much for talking to us about it. I wrote some notes, just giving a quick recap for any birth workers or support people that are watching this and saying, okay, what is exactly what I can do to help support? So first is bring up the option of, if you have somebody who you suspect is drug addicted or has told you that they are drug addicted, about the option of having methadone for safe withdrawal. Let them know about, stopping cold turkey being very hard on the baby. Learn Eat, Sleep, Console protocol to help educate your client and their family. Teach the appropriate comfort measures like we were talking about. If showing dysregulation, if the infant's showing dysregulation, help work with the clients to help regulate their systems and show them what are different things they can do for that regulation. Know the signs of withdrawal and tips to help make it easier, such as your tip with the diaper cream. A huge job for support people is going to be setting up the care team, preparing them for day 4 to be hard. So people that are your A-team support coming in on day 4, family, friends, potentially church members, cuddlers, postpartum doulas, and keeping in mind that methadone is going to be separate at a separate clinic. And so helping to set up exactly how that's going to work. No NICU support protocols to help support your client through that if needed. And then help kind of walk them through what discharge might look like should they end up in the NICU, or just in general if they get discharged before baby and all of that.
Yeah, that's fantastic. Yes.
Okay. So
And the
that's
methadone,
a recap.
yeah, great. That's wonderful. The methadone is typically used specifically for heroin withdrawal.
Okay.
So so just know that. Yeah, so I love it. Yeah, ideally we're connecting with these families ahead of time so that we can just give them education on what to expect and let them know that they will be welcomed with open arms. This is being used it's been used in the Kansas City metro area by St. Luke's Health System for a while, and then HCA is adopting it, and yeah, it's just a really good positive thing for families and moms and babies and dads and all the other caregivers. Yeah.
Yeah. Well, awesome. I'm really excited that you guys are adopting it. It sounds like this is going to be really, really helpful. And thank you for providing the education for, support team to be able to make it even more successful.
Yeah, thanks for the opportunity to share this. I'm so passionate about it and the help it's going to give families.